All right, hi everybody. I'm Josh Villarreal. I'm a second-year clinical informatics fellow here at Stanford, and also a general surgery PD resident. Really excited to talk about our work in automating video-based assessment for laparoscopic cholecystectomy. Our mentors for this project was Dr. Jeffrey Jopling, Srina Young, and Dr. Theodore Grantroff. Here are disclosures, none of which are relevant to this presentation, and our funding was provided by the Welcome Leap Save program, which is directed by our very own Tom Weiser. The Welcome Leap Save program is a 3-year moonshot effort to dramatically increase the number of surgical providers globally and also reduce postoperative complications. Our research team at Stanford focused on the second aim, which was to shorten the timeline needed to train surgeons using innovative surgical technology to accelerate skill acquisition. So to do this, we wanted to digitize video-based assessments specific on a standard procedure such as laparoscopic cholecystectomy. A lot of studies have shown the promise of AI in identifying surgical steps, automating errors, but they often lack actionable feedback. I think surgical video review is the future of surgical education, and it has a lot of helpful attributes in improving enabling personalized coaching and also performance improvement. Video-based assessments, an example of that is the modified OSAT score, actually pioneered by Dr. Grantroff. Very rigorously validated for human raters. However, it hasn't been optimized for computer vision, which lacks objectivity and also scalability. In order to first to train a model to identify certain surgical skills, we need to teach the model the steps of cholecystectomy. So using the framework provided by SAGES, we segmented or created a model for laparoscopic cholecystectomy, as you can see here, each with their own individual start and stop times, which I can go into more detail later. So what are we talking about by the surgical performance metrics, or what we call surgical meta-competencies? Thanks to a group in Japan who did a systematic review of all video-based surgical assessments, they did a thematic analysis and identified these 5 key surgical meta-competencies. Every surgeon in this room might have their own flavor or definition for each of these particular domains, but the most important part is their review showed visual discernible features, which were specifically for computer vision use cases. And so taking those particular skill domains and also adapting this, this is called the competency assessment tool, developed in the UK to standardize hemicolectomies for colorectal surgeons there. We used a similar 5-point Likert scale for our video-based assessment for cholecystectomy. And we also integrated language from the American Board of Surgery's intraoperative EPAs for cholecystectomy as well. And so this is the basic structure that we use for our annotators, going by the particular surgical steps for cholecystectomy, and then the meta-competencies. So our video data set consisted of 2 de-identified a multi-institutional IRB-approved data set of over 319 laparoscopic cholecystectomies. We broke each individual video down by those surgical steps, and then each step was broken down further into 30 to 90-second clips. So these individual clips, these thousands of clips, were annotated manually by our raters. I was one of those. And we use our 5-point VBA Likert scale. We did inter-rater reliability metrics. We use the Kendall's W. This is good for ordinal scales, such as our Likert scale. A score of, or Kendall's W of 1 is perfect agreement, 0.4 is acceptable agreement, and which we achieved on most of our inter-rater reliability metrics. We did form normative coercion with weekly consensus meetings amongst the raters. So for our model architecture, we use a state-of-the-art model called the Dino V2. It's a large foundational learning model. And we trained this model to differentiate between high and low performance. We bucketed our scores from our manual annotators, which was high scores from 4 to 5, and then low scores from 1 to 3. And we did a 60-20-20 train validation test split amongst all of the labels. And then for our performance metrics, we'll report our area under the receiver operating curve and 95% confidence intervals, which are obtained through bootstrapping. This shows the breakdown of the distribution of our clips. The majority of the clips that were labeled were from the dissection of the passes triangle, which is where the critical view of safety is achieved. The boxes that are highlighted show that the areas for class imbalance between the labels. So positive labels are the high performers clips, and then the negative labels are the low performance. So for tissue handling and for exposure quality, we did have some class imbalance there, which helps us interpret some of the output, the model performance metrics. So here you can see a graph of the area under the receiver operating curve with the confidence intervals as well. And although not perfect performance, this model does provide some signal for the trainee to at least identify the most teachable moments or areas to identify in the surgical video. We did have good performance for gallbladder exposure, for dissection quality, efficiency, and exposure quality, and also for the dissection and passes through triangle and exposure and dissection quality respectively. But there's still a lot of room for improvement and further iterations amongst our model's performance. So this is one step forward to automating and bringing to scale video-based assessments, which otherwise would be a very painful task for somebody to have to review many hours of video that they just don't have the time for. A couple of limitations I'd like to bring up. So one is there's lack of generalizability based of our the current videos that we use. We had 2 academic centers and then also 2 publicly available video data sets for laparoscopic cholecystectomy, but still larger multi-center data sets are required to have a better generalizability. Our inter-rater reliability metrics was not optimal, but something that we are continuing to refine and improve with better training. And we need to, most importantly, we need to correlate these AI metrics with clinically and educationally meaningful outcomes. Don't have time to go through a video, but here are some screenshots of now that we've developed these models, we've actually already applied these into a free web-based platform designed for trainees and by trainees. This is our error model, which identifies bleeding, bile injury, bile leakage, and thermal injury. We also have automated tool tracking to get the acceleration and velocity of your instruments. And the meta-competency models, as you can see here, where the green bars indicate adequate performance, and then the smaller red bars indicate the inadequate performance or areas for improvement. And then we can aggregate all these metrics over time so that the trainee can see their performance. And we plan to, our next steps is to do a pilot study, which we actually have here at Stanford, to have residents work with this model and have a coaching session with trainees and faculty to interact with the model and further refine its features. And then we also want to do a modified Delphi of the VBA to improve its language. Thank you.